Okay. All right, good afternoon, everyone. On behalf of the Manitoba government, I want to begin by honoring the sacredness and importance of this land. We are gathered on Treaty 1 territory, the ancestral lands of the Anishinaabe, Anishinaabe, Dakota Eate, Dene Sulene, Nihitawak nations, and the homeland of the Red River Métis. We acknowledge that northern Manitoba includes lands that were and are the ancestral lands of the Inuit. We respect the spirit and intent of treaties and remain committed to working in partnership with First Nations, Inuit, and Métis people as we walk on the shared path of truth and reconciliation. I also want to acknowledge the difficult time that we are all in as Manitobans during this state of emergency. I want to thank all of the Manitobans who have stepped up to support those being impacted by the wildfires. It has been truly amazing to see the incredible and rapid and caring response of those across our province and from outside Manitoba's borders to support those who are in need. Today I'm joined by Dr. Marcia Anderson, WRHA board chair and physician, and also joined by Dr. Sean Young, the chief operating officer at Health Sciences Centre. We're here to share details of the important work that is advancing the Truth and Reconciliation Commission's calls to action for healthcare here in Manitoba. As the Minister of Health, I am committed to building a healthcare system that is effective and equitable for all Manitobans. Healthcare experiences and outcomes vary significantly across racial and ethnic groups. These disparities are known and experienced but have historically lacked consistent and high-quality data. And that data is needed to understand and correct the problem. I'm glad to say that that is changing here in Manitoba. Our province is now a leader in gathering this data and using it to enact meaningful change. We are the first province in Canada to collect voluntary race, ethnicity, and Indigenous identity data from patients when they come in seeking care. This data will measure gaps in access, experience, and outcomes. It will inform interventions and help ensure equity for all in the care that's being provided. Data alone, however, will not fix the system, but we cannot fix what we do not measure, and that is why this work is so important. Under the leadership of Dr. Marcia Anderson and in collaboration with the University of Manitoba's Angomazin Indigenous Institute of Health, we have collected and analyzed wait times and care delivery in Manitoba's emergency departments. This is part of our broader strategy to close health outcome gaps, especially amongst Indigenous, Black, and racialized community here in Manitoba. The initial analysis shows that no matter where you are receiving care, no matter where you stand in the system, whether you're receiving care or delivering it, systemic racism is making that harder for you. For patients, racism, systemic or otherwise, is a contributing factor in their health outcomes and how long they wait for care. For staff, racism and discrimination contributes to burnout and staff turnover. Neither is acceptable and neither is inevitable. With knowledge in hand, we will identify where inequities exist. We will support culturally appropriate care and training that is grounded in anti-racism and strengthen public accountability and trust. Importantly, this work must be done with communities and not without them. These efforts are an overdue step toward equity, inclusion, and better healthcare outcomes for all Manitobans. And so today, we're really, quite frankly, thrilled at the opportunity to be able to be joined by an expert like Dr. Anderson and a provider and leader like Dr. Young, so that you can see the research and how it highlights the valuable work of physicians like Dr. Anderson and her team and folks who are doing this work. I want to note that Dr. Anderson has fearlessly pursued this data because she believes and understands that it's part of a solution to better care, not only here in Manitoba, but across the entire country. She's collaborating on the ground with leadership like Dr. Young of the Health Sciences Centre to put what she and her team have learned into direct practice. So I'm really glad that Dr. Young has joined us here today as the Chief Operating Officer of Manitoba's largest hospital. Dr. Young sees firsthand how staff and patients are impacted by discrimination. and he stands alongside hundreds of other system leaders, physicians, nurses, healthcare professionals who are ready to make change and who have been already taking action to make change. As a Black nurse myself, I have felt systemic racism on either side. I know how it feels and how damaging it can be. And I want to be clear, I want to be very clear for Manitobans, that the front lines should not be blamed for this, because this is the nature of the challenge that we're dealing with in front of us, that we all participate in systemic racism in one way or another. This is something that, whether we realize it or not, is a very real situation, not only here in Manitoba, but as I stated, it's a national issue. Our healthcare system here in Manitoba is absolutely full of people who know and understand that their career is in fact a calling. And every single day they do their work with compassion and with empathy and with the best outcomes in mind for their fellow Manitobans. Together, I know that we can build a healthcare system that sees all Manitobans, treats them fairly, and helps them thrive. So now I'd like to call upon Dr. Young to say a few words. Thank you.
Thank you. Good afternoon, everyone. I'm pleased to be joining Minister Asaguera and Dr. Marcia Anderson here today to be sharing this new data and some initial findings stemming from the voluntary collection of race, ethnicity, and Indigenous identity data. This is incredibly important work, which began following the release of the Truth and Reconciliation Commission calls to action, and in particular the call to measure and close gaps in health that First Nations, Métis, and Inuit people experience in the healthcare system. Recognizing that other populations and communities also experience the impacts of systemic racism in healthcare, it was clear this needed to be measured and addressed. As mentioned, if you're not measuring it, you can't fix it. I think Dr. Anderson and her team are taking on this vital work and already bringing it to a meaningful place with no template to work on. This is Manitoba data. We're the first province to be collecting and sharing data like this way. We're going to lead the country. Even though data released today focused on all the emergency departments, and with more specific data available for the Winnipeg emergency departments, we know that this is just not a problem just in the emergency departments, or just in Winnipeg, or even in Manitoba. Systemic racism is a problem across the healthcare system, provincially, nationally, and across the country. It is an issue that not only affects patients, but can also affect our healthcare workers. As a physician, I have seen firsthand how many of our staff have made efforts to address these very issues, and so too have health system leaders and care teams. However, this data confirms there is much more work to do to eliminate racism from our healthcare system in all its forms. The proactive collection and analysis of this data will help to inform our decision-making and will help to determine when real progress is made. It will help us deliver better and more equitable care and a more supportive workplace for all. Health system leaders like myself across Manitoba's health authorities are ready to tackle the challenges, identify new opportunities, and implement solutions, building further upon the work that has been done so far through the Health Systems Disrupting Racism initiative and other efforts to address systemic racism in healthcare. This includes the recently convened lower wait times and systemic improvements and system improvement team, which is working on system-wide initiatives to improve wait times and patient flow in the emergency departments and throughout the health system. Thank you again to Dr. Anderson and her team for carrying out this important work, and to Minister Asaguera for your commitment to addressing these issues, and to the many healthcare staff across the province who are working to counter racism in all care settings. Thank you.
Thank you so much, Dr. Young. And now I would like to give the floor over to Dr. Marcia Anderson, who's going to walk us through her data findings.
Thank you both. Hamatakape pate dutuman makiae chekota pichichi masiki squo nadishnakas nanduwe benisik nadishnakas chante washte nape chuzapaye. I've just introduced myself briefly and greeted people as my relatives. I've shared my Dakota, Korean, and Anishinaabe names, and I've said that I'm here today with a good heart, which is the heart that myself and my team do approach this work with. On May 11th, 2023, hospitals in Manitoba started collecting racial, ethnic, and Indigenous identity data from people accessing care. This work began following the release of the Truth and Reconciliation Commission calls to action in 2015. As Dr. Young mentioned, one of those calls is for us to identify and close gaps in Indigenous health and to report annually on the progress that we make. It was the commitment to respond to this call to action, as well as to disrupt systemic racism in all its forms, that led us here today. The purpose of collecting this data is to be able to measure the access to and quality of care that different communities in Manitoba receive so that identified gaps can be addressed. Our shared goal is for every person in Manitoba to receive the highest quality of care that our system can provide. For this initial analysis and release of the data, we focused on some elements of emergency department care. This was a high priority for all of the partners that we talked with, and it's also the site of care with the most data available right now. This is helpful because it strengthens our ability to disaggregate the data and report on it more accurately for different communities. As you can see on this slide, could you go back one slide? Thank you. Between May 11th, 2023 and September 30th, 2024, there were over 618,000 emergency department visits where the person's racial, ethnic, or Indigenous identity is known. These are the visits that we've been able to look into further. Only 8% of people decline to answer when given the opportunity to self-identify, showing this data collection is highly acceptable to the public. As you can see, the vast majority of visits, almost 87%, are by people who identify as either white or as North American Indigenous. This number of visits allows us to provide more detailed information by other factors like health region and triage score. For the population groups with smaller numbers, we cannot provide as detailed an analysis yet. Throughout this report, we'll try to highlight patterns for the largest 5 population groups: white, North American Indigenous, Filipino, African and or Black, and South Asian. As part of our plan, we will share additional information by health region directly with the regions. However, because more detailed data will result in smaller sample size for some population groups, at this stage today, we'll only be sharing information for the province as a whole, as well as for Shared Health and WRHA. As I mentioned previously, the majority of visits are by people who identify as white or as North American Indigenous. In this chart, we compare the proportion of ED visits by population group with their population representation according to the 2021 census. It's important to note that even though there are more visits by North American Indigenous people that you would expect compared to population size alone, that this is not enough to mean that ED use is inappropriate. This can reflect higher needs because of underlying health gaps, as well as lower access to other forms of care, such as primary care, that can help decrease the need for care in an emergency department. One of the ways that we use race-based data is to challenge harmful narratives that can compromise the healthcare different populations receive. One of these harmful narratives is that Indigenous people overuse the ED and use it inappropriately. As I move through the data, I'll highlight where the data does not support that harmful narrative. The next series of slides will show information about ED visits by triage scores and population groups. The Canadian Triage and Acuity Scale provides guidance on how to categorize patients so that those who are the most ill get seen soonest. Triage score 1 is the highest acuity score and is assigned to patients who are severely ill with conditions that threaten life or limb. Triage score 1 accounts for the fewest number of ED visits. Across different population groups, the proportion presenting to the ED with a triage score of 1 are very similar, ranging from about 0.7 to 1%. Triage score 2 is assigned to patients who need emergent care for conditions that are a potential threat to life or limb function. Among people who receive a triage score of 2, we do see some variations, with a relatively smaller proportion of North American Indigenous and white patients, as you can see, about 15%, compared to some other groups such as South Asian or Middle Eastern, where 18 to 19% receive a triage score of 2. Triage score 3 is the most commonly assigned triage score. It's assigned to patients who need urgent care for conditions that could potentially progress to a more serious problem. As with triage score 2, we see that there are relatively fewer North American Indigenous patients and white patients assigned this score compared to other groups, including Filipino patients and Latin American patients. The proportion of patients within each population group who are assigned a triage score of 4 is overall very similar. Patients who receive a triage score of 4 have less urgent care needs. When we look at patients who are assigned a triage score of 5, which means that their care needs are non-urgent, it's notable that there are higher proportions of North American Indigenous and white patients assigned to this lowest urgency triage score compared to other population groups. As mentioned earlier, one dominant narrative that can harm the healthcare that Indigenous peoples receive is that we overuse the ED and use it inappropriately. As the BC In Plain Sight report documented, healthcare providers may hold many stereotypes about Indigenous peoples, including Indigenous peoples being frequent flyers, and that can interfere with the quality of care. In this figure, if you look only at this line, which represents North American Indigenous people, and the bottom line, which represents white people, what is clearly shown is that there are no differences in the proportion of patients assigned each triage score. This helps counter the narrative that Indigenous people use the ED more inappropriately than the dominant population. As we examine the differences in the proportion of patients assigned these different triage scores, it's important to note that racism has been shown to affect the triage scores that Indigenous, Black, and other racially marginalized people receive. Prior research has shown that for both more urgent and less urgent complaints, white people are more likely to be assigned a more acute triage score of 2 or 3. This has been shown to affect markers of access to and quality of care, like the wait time to be seen, the wait time for diagnostic tests, and the total number of diagnostic tests done. When we look at the triage scores here, because of this pattern of evidence, which has been seen both in Canada and the United States, it's possible that Indigenous and African and or Black patients are systematically receiving lower triage scores than white people. Further work looking at where someone goes from the ED, for example, if they're admitted to hospital, as well as discharge diagnoses, will help us to understand the potential impact of this in Manitoba emergency departments. The other finding I'll highlight on this slide is that Filipino, African and or Black, and South Asian people are less likely to present and be assigned a low acuity triage score of 5, and more likely to be assigned a higher acuity triage score of 2 or 3. This demonstrates a tendency towards more severity of illness when seeking emergency room care. As we move forward now to examine wait times, please keep this finding in mind. In the next section, we'll explore the wait times to be seen for different population groups. The wait to be seen is the time from when a patient is assessed and triaged to when they are examined or treated by a doctor or other prescribing provider. In this figure, we are showing the number of hours that it took for 90% of the patients in each group to be seen. This is called the 90th percentile wait time. When we look at these numbers, we can see that African and or Black patients wait the longest. As shown by the triage scores earlier, African and or Black patients were less likely to present and receive lower acuity triage scores. More work is needed to understand and intervene in this finding to close the gap in wait times for African and or Black people. Similarly, Filipino and South Asian people wait longer than some other groups, even though they were also more likely to present and receive a higher acuity triage score. When we look at the 90th percentile wait times for adults in Shared Health and the Winnipeg Regional Health Authority, we see significant variation for different population groups, with African and or Black and North American Indigenous peoples waiting the longest. The differences are not as apparent at Children's Hospital. As mentioned earlier, the triage scoring process is meant to identify the patients with the most severe illness or injury who need to be seen first, and those who can wait longer to be seen. According to the CTAS education standards, each triage score has a goal time to assessment by a physician. Within each triage score, the wait times to be seen are expected to be fairly common without variations. Since there are relatively few patients who require immediate care with a triage score of 1, there isn't enough data to examine for systematic differences. This figure is showing variations for people who are assigned a triage score of 2, or emergent care needed, at Shared Health HSC, Shared Health Children's, WRHA, and all Manitoba facilities combined. These differences are about 1.5 hours in WRHA and almost 4 hours at HSC. At HSC, African and or Black and North American Indigenous peoples are waiting far longer, even for the second most acute triage score. The top 2 chief complaints, the things that people are coming in with to be seen for all people initially assigned a triage score of 2 are cardiovascular, for example, heart attacks, and gastrointestinal, for example, bleeding or severe abdominal pain. Looking at these top 2 complaints doesn't provide any further clarification of why the wait times would be so different for different population groups. For North American Indigenous peoples, substance use and mental health are among the top 5 chief complaints, which is different from other population groups. However, the triage score of 2 indicates that these were emergent presentations and as such required attention within the same time frame as others in this triage score category. In terms of understanding why this might not be happening, there was a study in Alberta where emergency room providers stated that if the perception is First Nations patients are intoxicated, they'll be parked in a waiting room chair for 6 to 10 hours before seeing a doctor. They said that First Nations patients will usually disappear, so people just almost ignore them. I'd also like to note here that some groups have general and minor listed in their top 5 chief complaints. I'll point out that this is a coding that's applied by a member of the healthcare team when we are rolling up the data for analysis, and not the complaint the person gave when they were being triaged. Among patients receiving an initial triage score of 3, we again see differences in wait times among different population groups at Shared Health HSC, Children's, in WHA facilities, and across the province. The differences are the smallest at Children's. And although not shown here, the chief complaints for people assigned a triage score of 3 are very similar. The 90th percentile wait times for triage score 4 also show gradients in wait times that are smallest at Children's and largest at HSC. In this category, among adults, North American Indigenous peoples experience the longest wait times in Shared Health and WHA facilities. Skin and orthopedic complaints are the most common tube complaints across all population groups. Substance use only shows up in the top 5 for North American Indigenous peoples. Given that the categorization we see here is applied by a member of the healthcare team, like that general and minor category, it's important that we are very aware of the common stereotypes about Indigenous peoples and substance use. It's important that we are aware of the medical mistakes that have happened with devastating consequences when healthcare providers have incorrectly assumed that an Indigenous person was intoxicated or only in the waiting room to sleep it off. Even when someone is intoxicated, they may be at the emergency room for care for another reason. And there are situations when those important reasons are missed by members of the healthcare team. Anytime we see a note about substance use and an Indigenous person, it's imperative that we ask ourselves what the evidence for that is, if it's possible that a stereotype has been incorrectly applied, and what else might be true or need further investigation and/or treatment. In triage score 5, we see similar patterns of variations in wait times across population groups, as we've seen in the other triage score categories. Again, although not shown here, there are no major differences in the chief complaints among population groups. We'll now turn our attention to people who ultimately leave the emergency room without being seen by a physician or other provider. Across the different population groups, North American Indigenous and African and or Black people are the most likely to leave without being seen, and white patients are the least likely. When we consider only the patients who leave without being seen, more than half identify as Indigenous. Wait times are known to be a key factor in whether someone decides to leave without being seen. The In Plain Sight report, as well as other studies, show that racism and discrimination are also reasons why Indigenous and African and or Black patients may choose to leave. This slide is showing the information on leaving without being seen for Shared Health HSC, Children's, and WHA. Similar to the wait times, there is variation in the number and proportion of people who leave without being seen. The information in this slide may be surprising to many. It was the information that was the most surprising to me. It shows that people across all triage scores, including those who need emergent care, leave without being seen and in surprisingly high numbers. It's reasonable to assume that for these most acute patients, this likely presents a risk to their health and may result in worse outcomes. Once people have seen a physician and a diagnostic or treatment plan has begun, sometimes people will choose to leave the healthcare facility and not participate in the ongoing care plan. This is categorized as leaving against medical advice. The vast majority of people who leave against medical advice are Indigenous, accounting for almost 2/3 of all patients who do. Similar to people who leave without being seen, people choose to leave against medical advice across all severities of illness, as represented by their triage scores. According to the In Plain Sight report, experiences of racism is a key driver of the higher rates of Indigenous people leaving against medical advice. Since this is a finding that has also been reported for African and or Black people, this will need to be monitored over time for other population groups as well. Our initial data analysis of access to healthcare in the emergency rooms across Manitoba show findings that are similar to other published literature. North American Indigenous patients present with remarkably similar triage scores to white patients, which counters against the common stereotype of Indigenous people using the emergency rooms more inappropriately. Although there is variation across the system, in many of the situations we examined, African and or Black and North American Indigenous patients wait the longest to be seen. There are more differences in results when we look at the rural regions, and we will be providing more data directly to the regions later this week and working collaboratively with them. Within each triage score category, there are significant variations in wait times, which are larger than what would be expected for individuals who were assessed by the triage nurse as having the same priority need for seeing a physician. This is not explained by systematic differences in chief complaints. There is more work to be done. This is a large and complex data set, and we will continue to refine the data and understand it further. We need to layer in additional elements, including age and gender as we currently have it represented in the healthcare system, to understand how intersectional identities and experiences may influence healthcare as well. This will need to be paired with workflow and patient journey assessments to understand where bias is creeping into the care pathways and can be addressed. It's important to know that significant work has been happening across the healthcare and health professional education system that will help us respond to this data. There is a healthcare system-wide public commitment to disrupting racism in all its forms. Some health regions already have anti-racism policies in place, and other regions are actively working on them. The Rady Faculty of Health Sciences has an anti-racism policy with significant opportunities for related education for faculty and staff who are teaching our future health professionals. The Max Rady College of Medicine has a 70-hour longitudinal course in Indigenous health that includes anti-racism and is increasing content related to other forms of racism. Shared Health is developing a learning module in anti-racism. The College of Physicians and Surgeons of Manitoba passed a practice standard supporting practice to eliminate anti-Indigenous racism that includes mandatory educational requirements for physicians. We all have a role to play in addressing racism, and as evidenced by these actions across the system, we are all committed and in this together. Since we began looking at this data, we've been regularly meeting with different members of the Provincial Emergency Department clinical teams. We all share the health system's commitment to disrupting racism in all its forms, and specifically in acting on the gaps that our data has shown here today. We want to note that as we continue to build the robustness of this data set, we will look at other clinical areas where we are also likely to see gaps in the care that African and or Black, Indigenous, and other racially marginalized people receive. Systemic racism in healthcare is not isolated to emergency departments. Emergency departments are very stressful environments, and the health system is facing many challenges in these areas. Unfortunately, in a system under stress, it is often those who are the most marginalized and who have the fewest resources to draw on who face the most severe impacts. Chronic staffing shortages and experiences of racism and aggressive behavior that emergency room team members face only add to and exacerbate these stressors. In a local study, 86% of Black, Indigenous, and racially marginalized emergency room providers experienced racism in the workplace, and 63% of white emergency room providers experienced discrimination. And yet, these team members show up day after day, trying their best to provide quality care within these system constraints. It's important that we all see this data as an opportunity to learn and grow together to improve the experiences of patients and healthcare team members alike. As an immediate step, we have recommended that all emergency department team members be prioritized for participation in the We Will Take Good Care of the People Indigenous Cultural Safety and Anti-Racism training. This training was developed by Ongomazin in partnership with Shared Health in the health regions. It is the first of its kind to offer one-on-one personal sessions with trained coaches who are equipped to support healthcare team members to apply what they are learning to their everyday real-world challenges. There are other training options that also can be accessed, including the First Nations Health and Social Secretariat anti-racism training as part of the lifelong journey in anti-racism that is needed. The data also highlights the need to specifically understand and address anti-Black racism. We recommend that priority be given to participation in the Black Health Primer. This primer was developed by the Black Health Education Collaborative to empower learners with tools and resources to address anti-Black racism in the Canadian healthcare system. The REI Data Project team has been meeting with the Emergency Department Program Clinical Team, as well as the Lower Wait Time and System Improvement teams, to collaboratively design next steps forwards. This includes designing potential interventions and establishing timelines to review new data and monitor for improvements. Evidence-based interventions, as well as community wisdom around what will make emergency department waiting rooms and care environments safer and free from racism, are being considered. There are champions in Manitoba's emergency departments who have shared recommendations that will also be further considered, including de-escalation and bystander intervention training, posting anti-racism policies and commitments, and revising waiting room announcements to explicitly include messages of welcoming and belonging. This collaborative approach to finding solutions will build on the strengths of all in responding to the needs of all. It will take time to close the gaps in wait times that our data has demonstrated here today. However, we would like to thank every person who has given patients the opportunity to self-identify and every person who has shared their racial, ethnic, or Indigenous identity with the healthcare system. You have been a critical part of ensuring that we can make these gaps in healthcare visible, which is our starting point for making a difference. Thank you for what you have done to improve the quality of care for every person in Manitoba that seeks it.
Thank you so much, Dr. Anderson, for that really important and comprehensive presentation and for your work. Thank you so much for the work that you and your team have been doing for years on this front to make healthcare in Manitoba better for all Manitobans. This work is so important in advancing equitable outcomes for everybody in our province who accesses healthcare. We're already taking steps in the right direction. I know that seeing all of that information can feel daunting, but it is really important to emphasize that there's work that's already underway. There's good work that's already being done across the healthcare system and certainly on the front lines by the front lines. So in taking those steps, what we're doing is accurately identifying and addressing the systemic barriers to ensure that we're providing adequate care for Black and Indigenous patients, families, and communities. So along with the collection of REI data, our government has enacted policy changes and set up a dedicated team of leaders committed to finding solutions. As Dr. Anderson has already said, there's a number of partners who are involved in doing this work. This is a team effort, and our government is committed to being a partner at the table doing this work alongside experts. Our province should be proud. I know many Manitobans are proud, but everyone should be very proud of the fact that we are the first to collect this data that is answering the Truth and Reconciliation Commission's 19th call to action to identify and close the gaps in healthcare outcomes between Indigenous and non-Indigenous communities. This data is, unfortunately, not unique to Manitoba. We know this. Other provinces across the country experience similar harmful realities, and we do look forward to seeing how other jurisdictions do their work to address these systemic issues using measurable data. And we look forward to working with partners across the country so that we can share what we're learning in Manitoba and how the work is being done here on the ground. We want to make sure that we're playing our part to support folks in having better outcomes, not only in Manitoba, but certainly across the rest of the country wherever possible. So again, I want to thank Dr. Anderson for her detailed and important work on this, and now we're going to open the floor for any questions. Thank you.
Dr. Anderson, you've been absorbed with this data for years. What stands out to you? Does anything surprise you?
So I have been immersed in this data for a number of years. I would say little of it surprises me, just because these are patterns we've known about in the literature. It's just hard to act on findings from the literature if you don't have a way to measure local progress. All right. One of the things that surprised me was one that I referred to in the presentation, and that was the number of people who leave without being seen, even when they have very pressing acute care needs, those who've received a triage score of 2, for example. Similarly, when I shared the data about those who leave against medical advice, it stood out to me that over 100 Indigenous people who came in with an initial triage score of 1 ended up leaving against medical advice. I think what that points to for us is that there is more work to be done and more supports we can offer, ensuring the building of positive therapeutic environments, in accessing the strength of all members of the healthcare team and supporting each patient who needs the healthcare that we can receive. And that would be a priority for me to see some of those numbers coming down.
When you were talking, Dr. Anderson, about we will take good care of the people, how many people have signed up for that training, and is it something that's provided during work hours, or is it something they have to do on their own time? What can you tell us about that?
Well, I can mention a few things. There is some variation in the responses to some of those questions. I can tell you, as of right now, we could easily accommodate 3,000 people from the Rady Faculty of Health Sciences and from across the healthcare system in the training in this upcoming year, and that across the faculty and the regions, they are aware of how many seats they have to fill. We do have the capacity to increase that number as well to meet the needs, depending on how many staff the regions can free up to take the training. Whether or not that is part of paid employment time or on their own does depend on the individual employee or their status. I could tell you that at the faculty, we do generally include it as part of paid work time, but if I were to take it as an independent physician, as part of my continuing professional development requirements, that would be on my own time. So there is some variability in that.
Will this be mandatory? I think the language is like prioritize for placement. Like, is this a mandatory?
Sure, I can speak to that. So Dr. Anderson and her team and certainly leaders across the system have been working very hard to make sure that there's more access to these programs and training opportunities as the work unfolds. And as a government, our priority is making sure that we are doing our part to support the front lines, to work with colleges and regulatory bodies, to work with unions, to understand the best ways for folks to really access these learning opportunities. So it's not a one-size-fits-all. There are many different ways that we understand folks want to access these opportunities, and so we're going to work with our experts and frontlines and different stakeholders to determine the best approach. But fundamentally, we know that this is important. We know that healthcare workers also want access to these training opportunities. I can tell you as a healthcare worker for many years myself, when you spot a problem that you can be a part of solving, you want to be a part of that, and you want the tools to be able to do so. So this is really about providing healthcare workers with those tools and finding the best way to get those tools in their hands.
You mentioned, Minister, about experiencing systemic racism on both sides. Does this report validate what you know?
You know, I think what it tells us is that what we've been hearing anecdotally from Manitobans, situations that we've seen, data, quite frankly, to Dr. Anderson's point, that is not new. This is data information, whether it's studies, stories that have been shared for many years, that Manitoba now has an ability to quantify. We have real data that tells a story about what's happening in our healthcare system, and it's giving us all the opportunity to address it. And that, to me, is really, quite frankly, in the midst of what can be very daunting data and information, it's an incredible opportunity that we have in Manitoba to be a leader in this space and to really work together to improve the health outcomes and healthcare experiences for Manitobans. So I'm sure this information is validating experiences of patients. I'm sure this information is validating the experiences of healthcare workers. And on all sides of this, we want everyone's experience to be as positive as possible.
So now that you have this data, which I know is kind of just the start, there's much more to look into, what do you see, how do you see, I guess, addressing this moving forward? Like, is there immediate steps aside from the anti-racism training that can be done to address these numbers?
Well, sure. I think Dr. Anderson, maybe I'll throw it back to her in a second, has already talked about some of the next steps that will be taken. As a government, our priority is to build this data and what we've learned into a lot of the work that's already happening. And so Dr. Anderson and her team has been able to meet with the lowering wait times and system improvement team that we have established. It's not just about reducing wait times, it's about reducing and eliminating those gaps in the wait times that different communities are facing right now. Working with our partners like the CPSM, who's done great work in this space, working with our regulatory bodies, working with unions, working with the front lines. We heard stories and experiences, the Premier and myself, on our listening tour from racialized, from Black and Indigenous providers who were asking, what we could do as a government to better support them. So it's really about working collectively. The responsibility doesn't just fall with one person or one expert and their team. It's incumbent on each and every one of us to take this up as a responsibility. So as a government, we look forward to supporting the work as it moves forward and also working with our partners and taking the necessary steps in terms of resourcing this work, in terms of additional policy changes on top of what we've already done to make sure it moves forward.
What do you do with the public who is, creating some of these problems for racialized doctors and healthcare staff? I mean, how do you address that?
Well, I think one of the most important things we have to do is bring those pressures down in the healthcare system. As Dr. Anderson already stated, we know that when there's a lot of pressure and a lot of challenge in the healthcare system, that can get expressed in different ways. Folks who are already very marginalized and targeted can feel further harms or pressures from the system. We know that frontline staff can be on the receiving end of harms that they should not be receiving from anybody in any workplace. And so, making sure that we're staffing the front lines is a big part of this conversation, making sure that we are retaining, training, and recruiting diverse healthcare workers. We know that representation in the workforce makes a really big difference. And so it is a priority for us as a government to have a diverse healthcare workforce that has their needs met, that feel heard and valued on the front lines. And we know that there's a lot more work to be done. We've taken some steps in terms of policy, in terms of staffing. We've got over net new 2,000 healthcare workers, but we know there's much more work to do.
When the healthcare, sorry.
Could I clarify one thing, which is that in the study, as well as in the Shared Health Racial Climate Survey, when I mentioned that 86% of Black, Indigenous, and racially marginalized people experience racism in the workplace, just to be clear, that's not all coming from patients. That is also coming from colleagues, leaders, other members of the healthcare team in the workplace as well. So the educational interventions are really important, particularly when teams do it as a whole, because it increases their capacity to have conversations about things like racial microaggressions that people might not be aware of, like eye rolling or invalidating. It also can create a culture of safety where any member of the team is more able to intervene and say, hey, what did you mean when you just said that? Or I'm curious what the evidence for that was. And so just want to highlight that it's not just from patients, but that the team interventions are really important there as well.
Dr. Young, what could be done to help more people free up more staff to take part in education for workers in the hospital system?
Well, that's a good question. I mean, it really depends. There are so many different staff that we have in terms of what supports they have, whether you're unionized or non-unionized. As Dr. Anderson said, we as physicians, we take the course on our own time, on weekends or evenings, and that's the way it sits now, but we'll see where that evolves. I also support the idea of expanding this out as much as we can. We would all love everybody to take this, and it would be great if they could take it during working hours. But of course, when you've got staffing challenges as you do, that creates problems as well. So this is great work. It would be great to be able to get it supported in as many levels as we can. So.
I think one other thing I would add to that is, conversations we're having at the government level across departments are also involving post-secondary education. It's involving partners in other areas, recognizing that, once you're in the healthcare system and you're working on the front lines, we don't want that to be the first time that you're having access to this kind of training and education, right? We want to make sure that folks have access to these tools and these opportunities to learn and grow well in advance of being employed in our healthcare system. So we're working with partners across different aspects of government as well. And again, with regulators and other partners to make sure that we're broadening out our reach in terms of this landing in folks, their lived experiences, professional and post-secondary training as early as possible.
So that's the onboarding would be a great place for us to be able to build this program and make sure that people have the tools they need right from the early beginnings of their careers.
Have you taken this training?
I'm many hours into it. I haven't finished it. Yeah.
Because it's a 10-hour module, right? Or
It's how many hours is it total?
It's
more than
probably
10.
on average about 12 hours. It's asynchronous and online, and you have 6 months to fit that in with. So someone could do 1 to 2 hours a month of it and finish it within the time duration. And then there is the option for, we recommend 3 one-on-one contacts, 15 to 20 minutes with a coach, as I had mentioned. Hope Dr. Young, you'll take advantage of that. We have some excellent coaches, and we are working on the in-person consolidation workshops as well for teams to support that application to practice again. So there are several different options to support needed flexibility in the system.
So the coaching and one-on-one, that's part of the 12 hours?
Yes,
But it's an option.
it's an option.
Just complete the 12 hours, however it works for you.
You do have to finish all of the online content, and it can be supplemented by the coaching, which we strongly recommend.
Minister, do you want to throw to Zoom?
Sure, we can go over to Zoom now for questions.
Thank you, Minister. Yes, we have one reporter joining us on Zoom today. We'll follow our usual one question, one follow-up approach here on Zoom, and I'll turn it over to Michelle McDougall from the Brandon Sun.
Thank you very much for taking my question and for the thorough data and accompanying news release. Does anything jump out at you when it pertains to rural areas where we are here in Western Manitoba? Is there any data to support or illuminate racism is, sorry to say the word, worse in rural areas?
That's a really interesting question, and I will say we have more work to do with the rural regions in order to understand what the data is showing and then to be able to release it transparently as well. I can tell you the patterns are more variable, and so it's not necessarily North American, Indigenous, and African and or Black patients who are waiting the longest in every rural region. There are some differences in the patterns, but there are wait time gaps. They, I would say on average, are more in the range of what we see in Winnipeg compared to what we've seen at HSC. And so I think there are some unique challenges in the rural areas, and we need more time, frankly, to work with the rural regions in order to understand and meaningfully support them in addressing them.
Okay, thank you very much. Would it be okay if I jump to another subject and ask Minister Asseguera about a news conference that was held this morning by Doctors Manitoba? Is that acceptable?
Of course, please.
I would go ahead and ask your question, yes.
There was a news conference this morning held by Doctors Manitoba about eliminating sick notes. Has there been any movement from you folks as far as a commitment, setting limits on employers demanding sick notes?
That's a really great question. I want to thank Doctors Manitoba for continuing to bring this issue forward and to advocate for this. This is an area that the work is ongoing, so labor and immigration has a big role in this. Labor has a big role in this, and so that work is ongoing right now. We're at the stage of really reaching out and doing those consultations and hearing from employers and the public and getting all of that information together. But it's certainly on our radar. The work is underway, and we continue to engage with Doctors Manitoba and other folks on this one.
Thank you, Minister. That's all from Zoom. We'll send things back to the room.
I'm just going to follow up on that Doctors Manitoba thing. Is this something you're committed to doing, though? Like you mentioned work's happening, but
sure.
do you want to get rid of sick notes? I think, Dr. Manitoba wants a legislative change of under 10 days or less.
Sure, yeah. I think that this has been very, very clearly communicated as a priority by Doctors Manitoba and by physicians. It's a national conversation. And in Manitoba, this is something as a government we're taking a good look at. We just want to make sure we're doing it the right way. So making sure that we're having all those conversations, doing the consultation. Labor right now is bringing this to a committee and doing that work. So the work is underway. I had a good chat with Doctors Manitoba recently about this, so we're just keeping those lines of communication open, and we're committed to making sure that we hear from the folks we need to so we can progress this properly.
You're interested?
Oh yeah, of course, definitely. We're as a government, our priority is strengthening healthcare. Our priority is making sure that physicians want to work and practice in Manitoba, that we're lightening their administrative burden, that we're supporting employees to have the work-life balance that they need as well. So, of course, we're taking a good look at this. We're interested, and those partnerships are really valuable to us as we move forward.
On another unrelated topic, we've recently seen Alberta has decided to start charging for COVID-19 shots. Wondering if Manitoba is looking to go into that direction.
What I can tell you is that vaccines are important. We are a government that believes in science, and we really encourage folks to talk to their primary care providers, your doctors, your nurse practitioners, your pharmacists, to learn about vaccines. If you have any questions, get them answered and get vaccinated to protect yourselves, your loved ones, and your communities. It's interesting as we've heard some PC members, the leader of the PC, Zabi Khan, talk about how he would love to privatize healthcare. Our government is taking a completely different approach. We are making sure that COVID vaccines are available and will be free for the public, because we recognize it's one way, it's an important way for folks to keep themselves safe. So that's the approach that we're taking as a government. We believe that vaccines are really, really important. We know they're important, we know they're safe, and we encourage folks to go out and get themselves protected when the time is ready.
So no plans to charge for it?
No, COVID vaccines will be readily available for Manitobans at the right time. There'll be no charge. And again, there are lots of vaccines that we're encouraging people to get. We listen to our public health experts, Dr. Rousset and other folks. Measles vaccine is a good example. We're encouraging folks to, if you're eligible and it's appropriate, get that vaccine as well.
Dr. Anderson, on the report, white people are more likely to get a higher acuity score. Why do you think that is? Like, is this that perhaps their concerns are being taken more seriously than perhaps other demographics? Like, is that perhaps a takeaway from that?
I think that is likely the correct interpretation. That particular statement is related to other published research reports. We have a commitment to examine that further here with Manitoba's data. There are some well-known stereotypes that interfere with how some people are assessed compared to others. I had mentioned the stereotype about Indigenous people being frequent flyers, the stereotypes around substance use and how that can interfere with it. One that's common for African and or Black people, which even as recently as 5 years ago, a study of medical students showed that many medical students still believe that African and or Black people experience less pain. And so stereotypes like that really impact how people are assessed and how they may be triaged. So yes, that's what I think is happening.
Maybe a related question then. This is from the report as well, African and or Black patients wait the longest to be seen, even though they are less likely to present in the lowest acuity triage scores. So also a little hard for me to understand that sentence. So can you both explain that sentence?
Yes.
And what could be the
Yes. So the people receive triage scores so that they are prioritized for when they need to see the provider first. We want the people who are the most severely ill, who have the most life-threatening illnesses or injuries, to be seen first. We all agree with that, right? 1 is the most urgent score, 5 is the least urgent score. African and or Black people were had among the lowest proportions of people presenting with triage score 5. So when I see that African and or Black patients are waiting the longest, I know it's not because they're presenting with the least acute illnesses. I know it's not because they could stand to wait the shortest, right? So there was something other than the level of severity of illness why African and or Black patients are waiting the longest. And then as we showed, those gaps within triage scores too, right? Everyone with the same triage score should get seen in roughly the same time. There is no good reason why African and or Black patients are waiting up to 4 or 5 hours longer than some other patients with the same triage score to be seen. And that is where we would argue that that's mostly influenced by patterns of systemic racism.
When looking at all this data, and I know there's still a bunch of unanswered questions, and you're still working through it, but was there anything that you weren't able to determine at all, or either there was no data for it, or kind of when you looked at it, it just didn't make sense?
More that there isn't data for everything that we would like to see. So the way we generate this data is by linking the identifiers, the racial, ethnic, or Indigenous identifiers, with the administrative data sets, right? So from that, we can see when a person comes in, when they're triaged, what the triage score is, the chief complaint, things like that. And then there's a note of when they are seen by a physician or prescribing provider. From the administrative data sets, it's really hard for us to tell what is happening between those 2 time points, okay? So for example, the healthcare system does have policies and procedures around how frequently someone should be reassessed while they're waiting, right? So we don't always know what's going on, like in that 4 or 5 hour gap. We don't know how the patient is experiencing the waiting room. So that is where being able to do some of the workflow and patient journey assessments will be helpful. This is also, quantitative administrative data. There are other ways to collect data, and so looking at what might be available through patient experience surveys, through qualitative measures, storytelling, and then like was previously mentioned, we have a workforce of really committed people who are going to want to be part of the solution, and so even talking to other frontline healthcare team members about what they're seeing, what the opportunities to fill in the gaps in the data to help us intervene will be important.
Is this going to be a benchmark, like in 5 years from now, you'll look at the same data sets and see where we're at? Like, how will this be useful in the long term to see if whatever you're doing or are doing now is working?
Yeah, our commitment is absolutely to use this as a benchmark. Today, we're talking about some hard truths. Going forward, we hope to be able to share markers of progress. Our plan wouldn't be to wait for a full 5 years. We think, particularly because we're doing this very collaboratively and also with the wait times and system improvement team, that embedding anti-racism in those approaches, I would like us to be able to be measuring again continually every 6 months, every year, and then reporting publicly on the process that gets made. It takes time, so we might not see wait times decrease right away, but we might be able to say, for example, this is the number of interventions, like the triage at the physician at the triage desk, that have explicit anti-racism actions included in that, for example. And then over time, we'll be able to see those differences in wait times as well.
Does anyone else have questions? All good? Okay, thanks guys.
Thanks, Zoom.
Thank you.
Thanks, Dr. Young.